right, so it is now 2:02. I think we will go ahead and get started. So thank you everyone for joining the October Pharmacy Section Journal Club of the Neurocritical Care Society. My name is Andy Webb. I am a neurocritical care pharmacist at Massachusetts General Hospital, and I'm very excited to have the honor of moderating today's Journal Club. I am joined by my co-moderator, Kimberly Levister-Franklin, who will be helping me with moderating the Journal Club today. And of course, we have two excellent presenters, Dr. Jacqueline Lang, who is a PGY2 critical care resident here at Massachusetts General Hospital, and Dr. Shema Al-Zaidi, who is a PGY2 critical care resident at Brigham and Women's Hospital. Both will be presenting outstanding articles. They were very excited to discuss the findings of these papers, and hopefully we'll have some great questions and great discussions. And we are going to kind of turn it over first to Dr. Lang, who will be presenting the INTERACT-3 trial. Before we get started, Jackie, sorry, just a few brief announcements that I feel like I must make. So first, as you're joining, please be sure to keep yourself on mute. At the end of the presentation, we will have time for some questions, of which you can certainly either put your questions in the chat during the presentation or at the end of the presentation, or you can come off mute to ask your questions then. Additionally, make sure to follow along on Twitter. If you do want to participate in the discussion on Twitter, you can use the hashtag NCSPharmJC to keep up with the discussion. You can also reference the discussion after the presentation. So with that, Dr. Lang, thank you so much, and you can feel free to get started.
Great. Can you guys see my slides in presentation mode?
Sure can.
Perfect. All right. Well, thank you everybody for coming today. My name is Jackie Lang, like Andy said, and I will be presenting on the third intensive care bundle with blood pressure reduction in acute cerebral hemorrhage trial, also known as the INTERACT-3 trial. All right, so I'm going to provide a brief background. I know we're all relatively familiar with acute intracerebral hemorrhage, but it accounts for approximately 10% of strokes annually in the United States. It's defined as a brain injury that's attributable to acute blood extravasation into the brain parenchyma from ruptured cerebral blood vessels. There's a lot of known risk factors that lead to acute ICH, including older age, greater than 55, hypertension, prior history of stroke, patients that are on anticoagulation are at higher risk, and then other causes include primary brain causes such as tumors and vascular anomalies. So when patients with an ICH present to our emergency departments and then subsequently to our neuro ICUs, we typically have a pretty standardized formation of how we manage these patients. So first, obviously, medical stabilization is going to occur. We want to consider our ABCs. Up to around 30% of these patients actually do require mechanical ventilation. Following that, we want to target some blood pressure control, which is really what we're going to be discussing today in more detail, some of the evidence behind that. But we typically recommend that pretty urgently upon confirmation of ICH diagnosis. Third is reversal of any coagulopathy. So if patients are on antiplatelet or anticoagulation prior to presentation, we need to consider whether or not that needs to be reversed. And then finally, prevention of subsequent complications. And this will include intracranial pressure management, blood glucose management, and fever prevention. So previous literature that's related to the INTERACT-3 trial goes back. There's a lot of different studies that we could discuss. The first one that I thought was relevant was the QASC study that was done in Australia back in 2011. This was a pretty large study, and it was the first study to really look at this bundled care approach in acute ICH patients. So their bundle was termed the FES bundle. So the FE stood for fever, and they maintained normothermia and tried to prevent fevers greater than 37.5 degrees Celsius. The first S stood for sugar, so this was the prevention of hyperglycemia. And then the second S stood for swallow, and that was basically they had nurses involved doing dysphagia screenings. This bundle was associated with significantly lower likelihood of experiencing mortality, as well as having an MRS greater than 2 at 90 days. The major takeaway was that from this was involving like a bundled approach for these patients and really kind of more interdisciplinary as well. With the dysphagia screening, they were getting nurses more involved. So it kind of protocolized care, and that was the first time that we'd really evaluated that. Another study that I think is relevant was the ICH ADAPT trial that was done in 2013. This is a smaller trial, but they looked at 2 different blood pressure controls within 1 hour of patient randomization. So they evaluated a systolic blood pressure of less than 150 versus a more lenient approach with a systolic blood pressure less than 180. And they did not find any difference in the rates of perihematomal edema, which was the primary outcome they were assessing. They also didn't see any difference in other clinical outcomes, and this included the 90-day modified Rankin score. Like I said, this is a much smaller study, so future additional studies were conducted, including the INTERACT-2 trial, which is kind of the predecessor of the INTERACT-3 trial that we're going to be discussing today. So this study was much larger. It involved around 2,800 patients, and it evaluated whether intensive versus more lenient blood control was going to have any difference in death or major disability. So the control arm, or the more lenient, was patients that had a systolic blood pressure greater than 180 could be treated at the discretion of the treating physician. And then the intervention arm targeted a systolic blood pressure of less than 140 for 7 days. I did want to note that this trial actually excluded patients with systolic blood pressures greater than 220 millimeters of mercury on admission. So the INTERACT-2 trial found that there was no difference in the rates of death or major disability between the 2 treatment arms, but they did find that the intervention group of the targeted lower systolic blood pressure group did have improvements in modified Rankin scale, as well as health-related quality of life. I did want to note there was also a post hoc analysis following the INTERACT-2 trial that found that elevations in systolic blood pressure, glucose, body temperature, and previous use of anticoagulation were all independently predicted to be related to poor functional outcomes after ICH. The next trial, the ATTACH-2 trial that was done in 2016, also looked at this difference of intensive blood pressure control for 24 hours following presentation versus a more lenient approach. So their intensive blood pressure control was defined as a systolic blood pressure targeting 110 to 139, and then their control arm was between 140 and 179. This trial did not find any difference in the primary outcome of death or disability, hematoma expansion, or neurologic deterioration between the 2 treatment arms. However, they did find that renal injury was actually higher in patients with the more intensive blood pressure control, and that was statistically significant. Following the INTERACT-2 and the ATTACH-2 trials, there was a pooled analysis completed in 2019 that was published in Lancet Neurology, and they looked at the effects overall of blood pressure lowering, and they included patients from both of these trials. So the pooled analysis found that it achieved systolic blood pressure was associated with functional status improvements, and they actually found improvements in functional status that was directly related to every 10 millimeters of mercury systolic blood pressure reduction. They also found that early and stable systolic blood pressure reduction was associated with favorable outcomes in these patients. To kind of provide a little bit more context on the actual blood pressures achieved in both the INTERACT-2 and ATTACH-2 trials, I think this figure is really helpful because it kind of gives us a clearer picture of what had actually happened in those trials. So first, the INTERACT-2 trial, like I said, the control arm was targeting a systolic blood pressure of less than 180. And as you can see in that first hour, the majority of these patients were less than that. So they were closer to around 160. And in the first 24 hours, most of them maintained a systolic blood pressure that was closer to 150. In the intervention arm, we were targeting a systolic blood pressure of less than 140. And you can see again, in the first hour, they were definitely lower than the guideline treatment arm. However, they were closer to 140 on the intensive treatment throughout the first 24 hours. Then in the ATTACH-2 trial, the control arm again was targeting 140 to 179. And as you can see, they were closer to that 150 range. And then in the intervention arm, they were actually much lower. So in the first hour, they were closer to a systolic blood pressure of 120, and they maintained that for the first 24 hours. So the guideline recommendations currently all have level of evidence B for the recommendations regarding blood pressure. So first, in patients requiring acute systolic blood pressure lowering, they recommend smooth and sustained control, which can be beneficial for improving functional outcomes. And this is related to that pooled analysis that we discussed earlier. Secondly, if they're presenting with systolic blood pressure of 150 to 220, acute lowering to a target of 140 is safe and may be reasonable for improving functional outcomes. And then finally, in patients with a systolic greater than 150 on presentation, lowering to a systolic blood pressure of less than 130 is potentially harmful. but we do not currently have any level of evidence A in the current ICH guidelines for blood pressure management. So that's where the INTERACT-3 trial comes in. This was published in late 2022, and it's going to evaluate the stepped wedge care bundled approach to treatment of patients with acute ICH. So the objective of this study was to establish whether a goal-directed care bundle protocol improves functional outcomes in a broad range of patients with acute spontaneous intracerebral hemorrhage. And the care bundle, which I will go into a little bit more detail, included blood pressure, glucose, body temperature, and anticoagulation reversal. It was an international, multi-center, prospective, step-wedge, cluster randomized, blinded, outcome-assessed controlled trial. They included adult patients with an acute ICH that was confirmed by imaging that presented within 6 hours of onset. And they excluded patients with evidence that the ICH was secondary to a structural abnormality, such as a tumor or something like that, and if they had previous thrombolysis. The majority of patients in this study were excluded because they were after that initial 6 hours of onset. They also excluded patients that had a high likelihood of not being able to adhere to the study treatment and follow-up regimen. The primary endpoint was 6-month functional recovery, which was evaluated with a shift in the ranges of score on the modified Rankin scale. Secondary outcomes that they evaluated included dichotomous analysis of scores on the MRS at 6 months, death at 6 months, death or neurological deterioration at 7 days, health-related quality of life, place of residence, whether they were at home, a nursing home, or still at the hospital at 6 months, and then time to discharge from the hospital. And then for safety outcomes, they looked at all cause as well as cause-specific adverse events. One thing I did want to note was for the primary outcome, they did look at 6-month functional recovery, and the authors of the study noted that they chose 6 months as opposed to 3 months, which is often done in our ischemic stroke trials because the recovery period for ICH patients typically is a bit longer. So for the methods, they completed this study in a step wedge design, which I think is a little bit confusing. So I tried to make it clear with this visual. So they divided sites and they randomized sites rather than patients into 3 different sequences. And each sequence would adapt to the care bundle when the time was appropriate for them. So on the first period of time, all 3 sequences, including all of the sites, were on the usual care. So they did not have any intervention. But then over time, as these periods started, sequence 1 would adapt to the care bundle and the other 2 sites or sequences would maintain usual care. Period 3 would continue the care bundle in sequence 1, and then sequence 2 would start the care bundle and usual care would continue for sequence 3. But then as you can see in period 4, all 3 sequences in all of the sites were utilizing the care bundle, and there was actually no arm doing usual care at this point in time. For the intervention and what the bundle actually included, so for early intensive blood pressure management, they tried to target a systolic blood pressure of less than 140 within 1 hour of randomization. And then once they reached a systolic of 130, that was their threshold for treatment cessation. For blood glucose management, for non-diabetic patients, they targeted a glucose of 110 to 140 milligrams per deciliter. And then diabetic patients, they targeted the 140 to 180 milligrams per deciliter. For pyrexia, they just had a goal of achieving a body temperature of less than 37.5 within 1 hour and maintaining that for the 7 days. And then for reversal of abnormal anticoagulation, they utilized FFP or PCC with the goal of reaching an INR of less than 1.5 within 1 hour. And like I said, the components of this bundled care were continued for 7 days after randomization. For statistical analysis, it was a relatively complicated statistical analysis that they completed, but they designed it with a 90% power and set their alpha at 0.05 to detect a common odds ratio of 0.8 for worst functional outcomes at 6 months utilizing ordinal logistic regression. And the required sample size of 8,360 was determined from 110 sites. They had an intra-class correlation coefficient of 0.04, and that was based on the results of the INTERACT-2 trial as well as the HEADCOAST trial. And then all analyses were undertaken at the patient level with adjustment for clustering. The main analysis performed was on a modified intention to treat basis, and they included all participants who provided written consent and had the primary outcome available, regardless of protocol adherence. So for the results, these are the baseline characteristics. I included some of the ones that I thought were most relevant and important to point out. So first of all, the majority of these patients were male. As you can see, only about 35.6% in both groups were female. There were 3,221 patients assigned to the care bundle and 3,815 patients that were in usual care. Other things that I thought were relevant to point out was the modified Rankin scale prior to symptom onset, and the majority of patients in both groups was relatively low, 0 to 1. So these were pretty high functioning individuals prior to their presentation. The next thing that I thought was worth noting was whether or not patients were on anticoagulation prior to admission. Only about 1% in both groups were on any anticoagulation prior to admission, which I thought was a little bit different from the patient population that I've observed here. As you can see, the majority of patients did have a systolic blood pressure greater than 140 on presentation, about 90% in both groups, and the presumed cause of ICH was hypertension vasculopathy in the majority of patients in both groups as well. Another thing I wanted to note was the high systolic blood pressure on admission. So as you can see in both groups, they included the range here, and they went as high as 280 and 284. I thought this was worth noting because in the ATTACH-2 trial, they actually excluded patients with a systolic blood pressure greater than 220. So we are including a wider range of patients. And then finally, for INR greater than 1.5, it was a very small proportion of the patients, only about 1 and 1.6% in both groups. As far as bundle implementation, I thought it would be helpful to kind of go through what the results look like for each different component of the care bundle. So for blood pressure management, any antihypertensives given intravenously in the first 24 hours was higher in the care bundle group compared to usual care. Additionally, the majority of patients in both groups did achieve their systolic blood pressure less than 140, but the time to reaching that target was lower in the care bundle group. And I think this graph really helps kind of show that difference as well. As you can see near the end, you do see very similar blood pressure targets. However, in that first hour or so, you do have a pretty significant difference between the care bundle group and usual care in terms of reaching a lower blood pressure. So I think that's where we see a lot of difference. For other components of the bundle, as we go through the other ones, you'll see the amount of patients that were actually treated for these bundle components decreases significantly. So for blood glucose management, the care bundle, only 250 patients in the care bundle group and 263 in the usual care actually had any interventions for their blood glucose, the majority of which were actually not treated with insulin, but rather with oral agents. And more patients in the care bundle group did achieve their blood glucose target. It was about 58.8% compared to 32% in the usual care. The time to reaching that target, however, was not different between the groups. For fever management, again, a very small proportion of patients required any intervention for fever. So in the care bundle, 52 patients compared to usual care, 68. And very similar rates of achieving that temperature less than 37.5 in both groups. And the median time to reaching that target, again, was very similar between the two groups. And then finally, for correction of abnormal anticoagulation, even fewer patients required any intervention in this, and the rates of achieving an INR less than 1.5 were very similar between the two groups, and that median time to reaching the target was also similar. For the primary outcome, patients in the care bundle group did demonstrate a favorable shift in the modified Rankin score at 6 months compared to the usual care group. And this was consistent across both the unadjusted and adjusted odd ratios with p-values of 0.015 and 0.017 respectively. However, the assumption of proportional odds was violated in this study. However, the analysis proceeded under the understanding that the treatment effect was not consistent across all modified Rankin score categories. Additionally, the care bundle was associated with a reduction in mortality at 6 months, and the odds ratio was 0.77 with a confidence interval of 0.63 to 0.95, so that was also statistically significant. In terms of adverse effects, patients in the usual care group were more likely to experience adverse effects compared to the care bundle, and that was statistically significant. In terms of adverse effects experience, that was really driven by CNS disorders, which include repeat cerebral hemorrhage, ischemic stroke, and herniation. I also wanted to point out that the incidence of acute kidney injury was actually pretty similar across both groups, and it was not significantly different between them. I think this is worth noting because we've previously seen in another trial that intensive blood pressure reduction was associated with an increased risk of acute kidney injury, and that was not consistent in this trial. So I think it's just worth mentioning and kind of thinking more about. So the author's conclusion for INTERACT 3 was that the findings provide evidence to support the adoption of an active protocol for intensive blood pressure lowering, as well as the management of some other key physiological variables, such as blood glucose, fever management, within several hours of the onset to improve the recovery of patients presenting with acute ICH. Now, there are several limitations to this study. First of all, usual care was not explicitly defined. They did this over many sites, so it's very difficult to really protocolize the usual care, which is kind of what we're trying to do by implementing the bundle. So we don't exactly know what they were doing prior to initiation of the bundle. Additionally, the step-wedge design is at a very high risk of confounding variables. Time was not on our side, especially in the setting of the COVID-19 pandemic. In the supplementary appendix, you can see there's a great figure that shows there was a period of time in which patients were receiving the intervention. However, there was no control arm happening, so it's very difficult to evaluate for confounding variables, especially because that was occurring immediately after the COVID-19 pandemic really started. So it's difficult to say whether our care practices changed. I think it's likely that they did, and I think that kind of limits some of the validity of this study as well. And like I said, yeah, the fourth period of the trial included only intervention with no patients in the control arm. And then finally, the medications that they use, I think, also limit external validity, which I'll go into a little bit more on the next slide. So this was interesting. Some of the medications they used, like I said, the majority of these sites were in lower income countries, so they utilized different medications. But I think it's worth noting, just in terms of the external validity, to comparing some of these treatments to what we do for our patients. So for intravenous antihypertensives, the primary agent that they utilized was urapidil, which is an alpha-1 antagonist. And this was the majority of what they used for patients. Second to that, also interesting, was sodium nitroprusside. About 20% of patients were treated with that, which I think is interesting because a lot of times in these patients, I worry about the ICP effects of sodium nitroprusside. Other things that they included as their IV antihypertensives included furosemide, nicardipine, and even hydralazine infusions. For antihyperglycemics, like I said earlier, the majority of patients actually received oral agents for the management of their hyperglycemia. This is not something that I typically see in practice here, so that's something I found noteworthy. And then for pyrexia treatment, the majority of patients actually received calf packing for the management of any fever. And then they also received a medication called metamizole, which is an NSAID currently not approved in the US as well. So my takeaway points are that the INTERACT 3 really builds upon prior evidence to support rapid management of elevated blood pressure to a goal systolic less than 140, especially in that earlier initial presentation period. I think it also emphasizes the need for institutions to protocolize management of patients with ICH to improve outcomes. I know there's a lot of initiatives in place right now to kind of develop these protocolized bundles in managing these patients, very similar to how we manage patients with ischemic stroke. We have endured in needle time and we have all of these set forth guidelines, and I feel like we're not quite there yet with ICH, and I think this study kind of pushes us in that direction to where we could have a kind of standardized protocol to help manage these patients and improve outcomes. So with that, I would be happy to take any questions and discuss.
Thank you so much for the fantastic presentation, Dr. Lang. You addressed a lot of the very interesting aspects of this article, and hopefully we'll be able to have some great discussion amongst the audience members. So for those of you in the audience, feel free to place your questions in the chat, and I could read them to Dr. Lang to discuss, or if you'd like to unmute, you're certainly welcome to do that as well. So I'll start. You briefly mentioned this as one of the considerations for this trial, and so I was hoping that you could talk a little bit about what your interpretation of how we could generalize the findings of this trial to the patients that you take care of at your institution, or kind of how we might be able to implement the findings across the country.
Yeah, so The way that I would utilize these findings is to really, as soon as I know I have a patient with an ICH, I would really start targeting that blood pressure and make sure that we're appropriately bringing it down and maintaining that consistently. And I think I would also start thinking about some of those other physiological values earlier. I think a lot of times we get stuck in the weeds and like very emergent things, which are really important to target early on. But also, I would start thinking about, okay, let's look at like their blood glucose and things like that. Unfortunately, with the amount of patients that were actually on anticoagulation in this trial, I don't think it gives us a ton of information on that component of the bundle. Although I know it's very important, but I think the primary things that I take from this trial is really that blood pressure management.
Yeah, definitely. I think the big thing that I often take away from this study is that, a bundle of care, be that what that is probably better than not having a bundle of care in terms of having a protocolized approach to taking care of patients with spontaneous ICH. One other thing that I was hoping you might be able to comment on is you also briefly mentioned the effect of COVID-19 on the results of the trial. So could you speak at all to how time may have played into the results and how we might be able to interpret, critical care and the quality of critical care overall in terms of how the impact of time influenced the results of the trial?
Yes, definitely. So there's actually a subgroup analysis forest plot that's in the supplementary appendix. The supplementary appendix is about 200 pages, but it's worth finding because it shows that the results of this trial were actually driven by the later period of this trial that happened after the COVID-19 pandemic. And so it's really hard to say whether like why exactly the results were pushed in that direction at that time. However, I do think it's likely that we improved just in critical care in general. I think also the pandemic had a lot of constraints in which like patients were in isolation rooms, providers were really tied up and doing other things. And I think that may have also had an effect. But I think that overall, like over the course of time, there was a significant improvement in outcomes following the COVID pandemic, and that is seen in the supplementary appendix. I think it's likely just a combination of things of improving in critical care, but also just having less constraints caused by the pandemic.
I mean, I think you would agree that.
Yeah, definitely agree that, time and kind of overall critical care being taxed, but also improving the quality of this practice, that's definitely an important aspect. So I guess before we move on to our next presenter, I'll open it up to anybody else with any other questions.
There's some strong words for FDB, but we'll.
Russ, I wasn't sure do you have a question? I saw you unmuted.
I think BJ and I could make a better system and help us, but we'll see. Thanks, Bob. I appreciate you going through this, though, and the clarity. I understand the frustrations with them.
But if nobody else has any questions, I think we can move on to our next presenter. Just as a reminder, if you're not asking a question, please make sure to place yourself on mute. And so next, I have the pleasure of introducing Dr. Shema Al-Zaidi, who is a PGY2 critical care pharmacy resident at Brigham and Women's Hospital. And she is going to be talking us through the TRACE-2 trial, which is tenecteplase versus alteplase in acute ischemic cerebrovascular events. So as a reminder, feel free to place your questions in the chat during the presentation or at the end, as well as following along on Twitter by using the hashtag NCSPharmJC. So Dr. Al-Zaidi, I'll hand it over to you.
Great, thank you so much for the introduction. As mentioned, I will be discussing TRACE-2 trial today. So just starting off with some background information, as we know that alteplase is recommended as a standard therapy for eligible patients who present with acute ischemic stroke, though recently we had this attention for TNK to be used or considered as an alternative option for patients with acute ischemic stroke. So TNK is a genetically engineered mutant of alteplase with amino acid substitution at 3 sites. These substitutions lead to decrease in plasma clearance, longer half-life, and increased fibrin specificities, as well greater resistance to plasminogen activator inhibitors. Both work the same way, both fibrinolysis by binding to fibrin in a blood clot and converting the plasminogen to plasmin. And to just put these two next to each other and look at the difference between TNK and alteplase, starting off with the FDA-approved indications, TNK is only approved for myocardial infarction, while alteplase has been approved for acute ischemic stroke, myocardial infarction, and massive PE. And as I mentioned, fibrin specificity higher for TNK, and also plasminogen activator inhibitor resistance is higher for TNK as well. Dosing regarding acute ischemic stroke for TNK, we usually do 0.25 mg per kg with a max 25. Alteplase, we do the 0.9 mg per kg with a max 90 milligram. For administration, TNK is an IV push over 5 seconds. Alteplase is a 10% as IV bolus over 1 minute, and the remaining of the dose will be infusion over 60 minutes. TNK has a longer half-life, as I mentioned, 24 minutes comparing with alteplase at 5 minutes only. For a cost, we can see that tenecteplase is less expensive comparing with alteplase. And to just look into the guideline recommendation that's back in 2019 AHA guideline and ASA regarding the use of TNK for acute ischemic stroke, we can see that they stated that it's reasonable to choose TNK as a single bolus of 0.25 mg per kg with a maximum dose of 25 over IV alteplase in patients without contraindication and who also are eligible to get the thrombectomy. Also, they stated that TNK administered as a 0.4 mg per kg single IV bolus has not been proven to be superior or non-inferior to alteplase, but might be considered as an alternative for patients with minor neurological impairment or no major intracranial occlusions. Both recommendations are level B. And stroke scales, I'm sure most of us are familiar with these. They've been using it as an outcomes measure for most of the studies, starting with the modified Rankin scale, which is used to measure the degree of disabilities in patients who had a stroke. From 0 to 6, the higher the number, the worse the outcome, or the worse the disabilities. And within IHS score, this is a systemic quantitative assessment tool that we usually use to just measure the stroke-related neurological deficit. And the higher the number, the severe the stroke. And I wanted to summarize and mention the previous studies that looked actually into the use of TNK and alteplase for acute ischemic stroke. And that started in 2010. We can see that initial trials actually looked into different dosing. I call them the dose determined trials, as they were looking into 0.1, 0.25, and 0.4, comparing these dosing with the standard alteplase dose. I bolded or highlighted these studies that I will talk more about, especially as outcome, and I chose these studies as they do compare both TNK 0.25 and alteplase standard dosing 0.9 as our study TRACE-2 trial. I also included TRACE-1 trial, which is the phase 2 of a TRACE-2 trial. They were looking at different dosing, but that's the initial or the first step of TRACE-2 trial. NORTHEST-2 trial, they looked into 0.4 mg per kg with alteplase, and we will look into the outcome of these trials. And I just wanted to as well mention that since 2020, we can see that there is more studies being published comparing both medication TNK and alteplase, and more attention or like interest shifted into the use of TNK for acute ischemic stroke. To just go through some of these studies I mentioned. So starting with ATIST trial, they looked into TNK 0.25 mg per kg comparing with the standard alteplase dose. And I included the key eligibilities for all of these patients, including the median NIH score and also the onset of symptoms time frame. So the first study looked into the supraarterial ischemic stroke. So they actually found that there is a positive there was no difference in the outcome, neurological or radiological, between both groups. The second study, Extend 1A trial, they looked at the TNK 0.25 and alteplase standard dosing, and they looked at large vessels occlusion, and they actually found there was a positive outcome as of radiological standpoint, there was more reperfusion into TNK group with no difference in the symptomatic ICH or the 90 days modified Rankin score. And TRACE-1 trial, they looked into different dosing of TNK, and they also looked into Alteplase standard dose, and this is the phase 2 trial. They included Chinese population, and they actually found no difference in IHS score at day 14, and also symptomatic, they looked at the symptomatic ICH, and they actually, from this study, shows TNK dosing of 0.25 to be more tolerable in this population, with 77.2% in improvement on an IHS score and 0% of ICH, symptomatic ICH. Northeast 2 trial, this is a trial looked into the smaller dosing with a 0.4 mg per kg comparing with standard dosing. And this is a trial that was actually stopped earlier due to the unfavorable outcome and the worse or negative outcome, as there was a worse safety and functional outcome comparing with Alteplase. As we can see that there was mortality at 3 months higher in TNK group, and also symptomatic ICH higher in TNK group. Any ICH as well was higher among TNK group. TASTE-A trial, this is a trial looked into the TNK 0.25 and standard dose of Alteplase, and there was a positive outcome among the radiological finding of smaller lesion volume among TNK group comparing with Alteplase group, though there was no significant difference among the 90 days modified Rankin score and also 90 days of mortality between both the group. It was the same. The last trial, which was one of the most recent trials and largest sample size of 1,600 patients, ACTA trial, they included many patients, all comer. They looked at TNK of 0.25 mg per kg comparing with the standard dosing of 0.9 mg per kg. What they found no significant difference among both the groups, but they actually did a subgroup analysis, which showed more trend towards superiority of TNK in patients with large vessels occlusions, which was one of the findings of earlier trial that I talked about. So moving to our trial, TRACE-2 trial. So the objectives of this trial was to evaluate whether TNK is non-superior to Alteplase in patients with acute ischemic stroke who were eligible for IV thrombolytic but ineligible or refused to get thrombectomy within the 4.5 hours of symptoms onset. And this study design set this trial apart comparing with previous studies. This is the only study that actually looked into this patient population. They actually did not get thrombectomy. So this is a phase 3 multi-center prospective open label blinded endpoint randomized control non-inferior trial across 53 centers in China. This study conducted between June 2021 to May 2022. They looked into TNK as a single dose of IV bolus at a dose of 0.25 mg per kg with a maximum dose of 25 over 5 to 10 seconds. And they looked at Alteplase, a dose of 0.9 mg per kg with a maximum dose of 90, within 10% of the dose given as a bolus and the remainder of the dose over 1 hour infusion. And this is similar to what we do in our practice. This study was funded by one of the pharmaceutical companies. They actually donated the both medication, TNK and Alteplase, but they did not play any role in the design or anything in the trial. They just donated both medication, and both medication came from the same company. So there is less likely to be any bias. Patient selection, they included adult patient 18 years and older, and also patient who are eligible to receive IV thrombolytic within 4.5 hours of their ischemic stroke. And also they included patient with modified Rankin score of no more than 1 before enrollment. And IHS score, they intended to or planned to do score of 5 to 25. They excluded patient who intended to or proceed to do the thrombectomy. For their efficacy outcomes, their primary efficacy outcome was to look into the proportion of participants with an excellent functional outcome, and they defined that as a modified Rankin scale score of 0 to 1 at 90 days. Their secondary efficacy outcomes were the proportion of patients with favorable functional outcome, which was defined as modified Rankin scale score of 0 to 2 at 90 days. And also they looked at the modified Rankin score at 90 days. The proportion of patients with substantial neurological improvement on the NIH score. And they also looked at the quality of life, different scales. They used European health-related equality, and they also used the Perthiel Index score to look at 90 days of outcome after receiving the therapy. For their safety outcome, the primary safety outcome, they looked at the rate of the symptomatic ICH within 36 hours. For their secondary safety outcome, they looked at the parenchymal hematoma, and they included their definition. And also they looked at any intracranial hemorrhage or other significant hemorrhagic events. They also looked at the death from all cause within 90 days of disease onset. And finally, they looked at the serious adverse events, and adverse events were collected until 90 days for both groups. For their stat analysis, they did a sample size calculation. Their final target sample size estimate was 1,430 patients with a plan of 715 in each treatment group for 85% power. At their primary endpoint, they actually did both modified intention to treat and per protocol population. They did non-parametric stat test dependent on the variable. And finally, they did the post-hoc subgroup analysis, counting for 6, bridging, thrombectomy, age, and IHS score, and onset to needle time. For their safety endpoints, they used intention to treat population. They did logistic regression or Fisher exact test as appropriate. So overall, the stat test was appropriate to evaluate the data. Moving into the result. So initially they included 1,417 patients. For modified intention to treat in T and K group, they had 710. For Alteplase group, they had 707. They mentioned the patient, why they were excluded. Most of majority, they were excluded because of the contraindication for thrombolytics, but also other reasons were mentioned. And also some of the patient lost follow-up. They were excluded to get the per protocol. They end up with 671 for T and K group and 642 for Alteplase group. The baseline characteristic, it was well balanced, but I just wanted to point out a few things here. Starting with the patient population, this is 100% Chinese patient population. And the other thing, that modified Rankin score before stroke at 0 was almost 90% among both groups, as they were planning to do. For the median baseline and IHS score, it was 7 for both the group, with 5 to 10 or 6 to 10 in Alteplase group. It was lower than they would expect, or they initially planned to do. The median door to needle in minutes, it was almost the same, about 60 minutes, which is the recommended from the guidelines. And I just wanted to point out that both group T and K and Alteplase was administered within 60 minutes, so there was no delay. Though when we think about T and K, it's easier for reconstitution and administration, though there was no delay or concern in that regard between both groups. And I just wanted to also point out that actually T and K is more expensive in China comparing with Alteplase, which is the opposite here in the US. So the price difference, it's different from country to country. It's just something to keep in mind as we go. So moving to the result from primary efficacy outcome, as I mentioned, they looked into the modified Rankin scale score of 0 to 1, which is excellent functional outcome. Both group modified intention to treat and per protocol, there was no significant difference between both groups, T and K and Alteplase. And this is just a visual presentation of the primary outcome, and we can see that there is no significant difference between both groups and both analysis, modified intention to treat and per protocol. And when also they did the subgroup analysis, accounting for different factors or variables, there was no significant difference in the primary efficacy outcome. For the secondary efficacy outcome, we can see that across the board, there was no statistically significant difference between both groups. That all the quality of life and all the improvement in IHS score, modified Rankin score, was almost the same among both groups. For the safety outcome, the primary safety outcome was the intracranial hemorrhage within 36 hours, which was not significant difference in there, and we can see it was 2% for both groups. And even with the other safety outcomes endpoints, there was no significant difference. ICH within 90 days or other things they looked at, death or adverse events or serious adverse effects, there was no difference among both groups. So the author's conclusion, they concluded that TNK 0.25 mg per kg with a maximum dose of 25 was non-inferior and not superior to alteplase 0.9 mg per kg with a maximum dose of 90 for disabling ischemic stroke within 4.5 hours of symptoms onset without thrombectomy. And I just wanted to move into the discussion points, just highlight some of the weakness and strength of this trial. So for strength, I would think that this trial has a large sample size, though they did not meet their calculated patient population. They did not meet the bar they were planned to, but they were close to it. They were planning to get 1430, but they only included 1417 patients. The efficacy and safety outcome was consistent with the previous studies as they looked at almost the same outcomes, modified Rankin scale scores, and also ICH, which make it easier for us to just compare the outcome of this study with previous studies as well. They did subgroup analysis for primary efficacy outcome for most of the variable that we would think would affect the primary efficacy outcome, and that showed no significant difference. So I think that was really helpful. And also they did intended to treat and per protocol analysis for their primary outcome. So we can see that if there is any difference between both, and there was no significant difference. And also they did TNK and alteplase dosing at the same as we do here at our practice. So that makes it easier to conclude or compare the outcomes of their study with what we actually do. The last thing I would think it's more of like a strength that they included only patients who did not get thrombectomy. Either they were ineligible or they refused to do so. I would think this is different from all of the studies that I discussed earlier. And this is the first study that actually looked at patient did not get thrombectomy, and this is different from also the guideline recommendations as they recommended TNK for only patients who undergo the thrombectomy. So I think this is one of the strengths to add on the literature and support the literature that we have for TNK for acute ischemic stroke. Though when we think of the weakness, this is a Chinese patients population only, though during their discussion part, they were discussing the outcome of this study, comparing it or combining it with the ACT trial as well, to just showcase that it's actually effective in Chinese patient population and to just make the conclusion more generable in all of the other population. I talked earlier about the study being underpowered as they did not meet the calculated patient population. The other thing is the unblinded medication administration. I know it's hard to just blind the medication administration since TNK is IV bolus over 5 to 10 seconds, comparing with the alteplase, which is bolus followed by infusion for an hour. I think there could be a way to do the blinded, though their explanation that why they did not blinded both medication as to just not delay therapy, which is reasonable. The other thing, they only included moderate stroke, a patient with an IHS score of 5 to 10. Initially, they wanted to include even severe severe stroke with higher NIH score, which I understand would be more difficult to include these patients, especially if they are eligible for thrombectomy. So my overall conclusion from this study and previous studies that currently literature support the use of TNK of 0.25 mg per kg with a maximum 25 is non-inferior to alteplase 0.9 mg per kg with a maximum dose of 90 and has similar safety outcomes for treatment of acute ischemic stroke in patients who do not receive thrombectomy. And TNK actually offers practical advantage, including simple dosing, faster reconstitutions, easier administration, and cost saving, at least in the US. And I just wanted to bring one more point before I end up my presentation, is just the formulary considerations. So at my institution, we actually transitioned to TNK last May for only stroke. So it's something to keep in mind if the transition to TNK is for all indications or only for stroke. The other thing is the packaging concern. As of now, TNK is only approved for MI, and the package, the box, it only has the MI dosing. So that could be one of the risks for medication error. And what we do here at Brigham, we do actually have our own stroke kit. So we do have this sheet with the dosing recommendation for based on the weight with a maximum of 25 meg. So this is something to keep in mind if we want to repackage, or if we want, I know other institutions just do a sticker to cover the MI dosing and do the stroke dosing. So just keep in mind that packaging concern would be something to consider. And the other thing is just no replacement program for unused TNK comparing with alteplase. So we'll not start mixing TNK unless we are like 100% sure that it will be given for the patients. And that's all what I have for the formulary considerations and for my presentation. And I will be happy to take any questions.
Awesome. Thank you so much for the fantastic presentation, Dr. Al-Saidi. So we will, like I said on the previous presentations, feel free to place any questions in the chat, or feel free to unmute and ask your questions as well. But we do have one question in the chat from Dr. LaVista Franklin. So her question is, based on your overall conclusion, is tenecteplase truly less expensive than alteplase given the lack of replacement program?
That's actually a good question. And I know this is one of the downside of TNK, that there is no replacement program. So I would think of it that I would not honestly start reconstitution for TNK unless I'm 100% sure it will be given, as if there is no replacement program. I know this could be one of the downside, and the difference, I guess the price difference from like last year, the year before was about 2K. Now it's almost like 1K. So I don't think it's actually a really from cost saving, since we do the repackaging and we consider like extra step. I'm not sure about like how much we are saving here. What I'm thinking more of being the advantage is that it's easier for like dosing wise, easier for especially transfer. It will be faster to just do the administration, 5 to 10 seconds, that being more of like advantage rather than the cost saving. I would think of it, we would save some money, but on the other hand, the other advantage would, you know, be more practical if we think about it.
Thank you so much. Yeah, I think that's a great answer to that question. That there's definitely balances in both directions. The next question in the chat is, you know, in your practice, do you use tenecteplase for wake-up strokes outside of the 4.5-hour window?
At my institution, we actually use it only within the window. Outside of the window or the wake-up stroke, I know there was one of the recent trials just published, or is about to be published. I'm not sure what was the outcome of that trial, but they looked at the use of TNK for wake-up stroke. I don't think it was a positive outcome though, but at my institution, if that answered the question, we don't use it outside of the window. We just do it within 4.5 hours.
Yeah, definitely agree that the wake up strokes and extended interval strokes is going to be the kind of the next area of interest for tenecteplase for sure. To your point, yeah, there was one extended window trial that was published that was neutral, but didn't use the advanced imaging criteria of extend or wake up. And Timeless, which is within 24 hours, hasn't been published yet, but also was a neutral trial. So more to come for sure. The next question comes from Dr. Gilbert. He's asking, does your management of tenecteplase associated bleeds differ from that of alteplase associated bleeds?
Yeah, so the management of the bleeds, I think this is a really great question. I did not look into more of the bleed difference, but I know with TNK we do give fibrin, and that was one of the case I've seen before. I'm not sure if that's different from alteplase, but I can look more into it, or if anyone can answer from my institution if they are on the line.
Yeah, I'd definitely be interested in hearing other people's approach to this as well. I think to your point, there's really no data on this. So I think it's a lot of empirical kind of approaches to these. So Brian, I don't know if you have any thoughts, or if anybody else on the call has any thoughts, or if they've approached these hemorrhagic conversions with tenecteplase any differently than how they've approached it with alteplase. Yeah, I can say, so Brian in the chat said that he doesn't like giving empiric TXA, but he still does fibrinogen supplementation to above 150, and Celia says pretty much the same. They'll reverse the same. And in my experience, it's similarly, where we will use cryo to get fibrinogen levels up. One thing that I think is kind of important to point out with tenecteplase is that the coagulation parameters don't tend to change nearly as much with tenecteplase as they do with alteplase. And so using an empiric fibrinogen concentration goal may actually fake you out, because tenecteplase likely is not going to drop your fibrinogen in the same way that alteplase does. But we'll typically just give the 1 to 2 pools of cryo per the stroke guidelines with or without TXA. But it's unfortunate that we don't have quite the same targets that we have with alteplase. Like looks like Jessica McManus said, yeah, based on a test coag, I've only been pushing Amicar. We need more data on that. So yeah, definitely a lot of variability in this for sure. And hopefully we'll have some more data on that as well. Yeah, Abdullah agrees, based on the mechanism of action, use the same reversal principles. And so Abdullah also has an additional question. He asks, can you please comment on inclusion criteria of ineligible for endovascular thrombectomy, but the subgroup analysis included bridging thrombectomy?
That's actually a great question. I did not think about it, but I will look back into the subgroup analysis. Yeah, I would think that most of the patients that were included in the study, they did not get any bridging thrombectomy, though there was few patients. I think in their supplemental, they were talking about why they did that initially, but I'm not 100% sure what was the...
Yeah, there's definitely some confusing aspects in the methods about no plan for thrombectomy, but if they got one anyway, they could still be eligible. So at least it is interesting to see that they still did that subgroup, even though there were just a handful of patients that ended up getting kind of a rescue thrombectomy, so to speak. Awesome. Well, thank you so much for your fantastic presentation. We are at the top of the hour, so we will conclude our journal club here. Thank you to everyone who joined the October edition of the NCS Pharmacy Journal Club. So make sure to check us out on Twitter. This will also be uploaded to YouTube if you'd like to reference it in the future. And also make sure to join our November NCS Pharmacy Journal Club, which will be on November 13th at the same time. So thank you all so much for joining, and thank you to our excellent presenters. And I hope you all have a great rest of your afternoon.